66-year-old gentleman. He's diabetic, he's hypertensive, and he underwent a PCI to LED LCX in 2002 for chronic stable angina. 2 BMS were implanted. About 3 into 16 EXP stents were implanted in this case in both LED and LCX, and he did well for 20 years. He was totally asymptomatic, but he came us to in January 2022 with symptoms of class 2 angina for 8 months and which increased to class 3 for 15 days. His ECG was normal and echo was normal function with no renal wall motion abnormality. His troponin was negative. So in view of recent worsening, we took him for angiogram. If we can see, this was the iliocranial view which showed normal left main, and LED stent which was implanted, proximal LED, looked some mild lesions in there, but the OM stent, which was, we can call it a Ramus stent, which was implanted, was having a critical stenosis in this case. And LCX was a small vessel having a significant disease in the distal part, but the myocardial value was less than 1. If we see the epicaudal view, the same findings were confirmed in this case, and there was significant disease in the OM stent, and LED developed a mid part of LED was showing about 85% of stenosis in this part, and LED stent was having a in-stent mild disease. His RCA was normal, and his LV function was normal. So what we were dealing with LED was having a mid-severe disease. LED proximal stent was having a mild lesion, which was not looking very significant but not confirmed. Diagonal was having severe disease, but the OM stent was having a critical in-stent restenosis of a 99%. So if we see the ISR PCI, we knew that we are going to tackle this case, and we all know that there are different factors. It's for 20-year-old. So imaging becomes an important modality in this case to assess the in-stent lesion or an in-segment lesion. So plan which we took that we will do with this OCT guided imaging of this PCI of OM, first to see what is the mechanism of in-stent restenosis, whether it was just an in-stent or in-segment. Since it was a BMS, can we go away with DEB, or we have to implant a new DES in this case? And do we need any additional modality to prepare for in-stent restenosis in this case? LED lesion have to be addressed mid-part, and for the proximal in-stent part, we have to assess what to do with this. So we did a PCI of OM. This was, if you can see, EBU, it was hooked, wired, dilated with 1.5 mm balloon, and OCT pullback was taken in this case. So interestingly, if we see, there was in-segment restenosis, there was definitely a fibrolipidic plaque which was distal to the stent also, which was not visible angiographically. There was new atherosclerosis in this case, good calcium arc was present with microvasculatures in this case. So this was not related to BMS. Basically, it was a new disease which has developed in this case, which was there. And proximal edge of stent was relatively free of disease. So this was the finding which we found, that the distal landing zone of 2.87, and there was distal 10 millimeter of disease extending from the stent edge with calcium arc present in the mid part with microvessels and a new atherosclerosis in this case. So what we were dealing with a well-expanded stent struts with calcium arc, heterogeneous and thick fibrous cap. So do we have to do anything extra in this case? So we planned, because there was a calcium arc was there, so we took a scoring balloon of 310 and tried to prepare the balloon. And since the landing zone of distal part was 2.75, we took a 2.75 28 cellular stent and we deployed it. Post-deployment, we knew the proximal part was 3 millimeter. We dilated with a 3 into 12 mm NC balloon, and angiographically it looked good. We did a post-PCI of this part. We found a good expansion of stent struts. Distal edge was clear, no stent edge dissection, but in the proximal part, the stent was little looking under-expanded in this case. So we did a 3.5 mm NC balloon in this part. After 3.5 mm NC in the proximal part, we found a good result of good TB3 flow and good expansion of this case. LED we did. To assess the LED, the mid part was having significant disease. So we first tackled this part, and evolution 2.5 or 24 mm stent was deployed in mid LED. and to see the proximal part of LAD. Do we have to readdress this part of proximal part? We thought rather going for imaging, we should go for a physiological assessment in this case. Either we can go for an FFR or we can see the OCT in this case to see what is the restenosis or what is the new intimal plaque, if any formation is there. We took help of FFR and we did an FFR assessment of the proximal LAD lesion, and it came to be 0.82, which was non-significant in this case. So this was the final result. With the help of imaging and physiological assessment, we were able to tackle both the stent of OM and LAD. So the take-home message is instant restenosis is considered as Achilles heel of PCI, and once the TLR develops, it becomes high risk of recurrent cardiac events. We all know BMS is associated with new intimal hyperplasia, but as the years pass, it is basically new atherosclerosis which becomes a predominant role in these cases. New atherosclerosis should be considered as a native atherosclerosis, since we saw this patient having a development of disease in other parts of arteries also. So this was basically a new aggravated atherosclerotic disease which was developing in these patients. If you want to see the protocol, what should be followed? In BMS, it is usually DEB. Data has shown that DEB is equivalent to DES, so DEB can be done in these cases. But in my case, there was a distal end stent was showing disease, and there was a new atherosclerosis formation. So a DES became a good choice for these cases. Thank you.